Welcome to the Deep Dive, where we transform complex clinical sources into crystal clear, immediately actionable insight.
Mm.
If you are stepping onto the neonatal floor, maybe you're prepping for a high-stakes exam, or you're simply driven to understand that intense, intricate balancing act required when a newborn faces challenges,
Uh,
well, this dive is custom tailored for you.
Today's mission is really laser focused on complicated newborn care.
Right.
We've synthesized a huge stack of extensive lecture notes and clinical protocols.
Right.
It covers everything from the whole spectrum of birth weight and prematurity to, critical challenges like jaundice, substance exposure, and even congenital anomalies.
And our mission here isn't just to define these problems. We want to give you a clinical shortcut. We are aiming for mastery of the critical nursing assessments, the immediate care priorities, and those essential interventions detailed in the sources.
Yeah, we're moving past theory.
Exactly. Right into the what do I do now
Yeah.
protocols that save lives.
What's really fascinating here is the interconnectedness of all these conditions.
Yeah.
The underlying clinical challenge for almost every complicated newborn, it doesn't matter if they are tiny and premature or large due to maternal diabetes, it's the same:
What is it?
physiological immaturity or compromised stability. So we'll spend a lot of time exploring not just what the condition is, but the precise rationale, the clinical why certain assessments like ensuring warmth or checking blood glucose are just non-negotiable across almost all risk categories.
Okay, let's unpack this. We have to start where every comprehensive assessment begins, the scale and the physical appearance of the baby, because really, size is often the very first red flag.
It is.
So let's start with the statistical baseline. What actually constitutes a normal newborn?
Well, the sources define the normal term birth weight as falling between about 2,500 grams and 4,000 grams.
Right, that's a pretty wide range.
It is, but newborns who fall into that appropriate for gestational age category, or AGA, they represent the vast majority, something like 80% of all births. And they carry the lowest statistical risk of morbidity and mortality. They're really our benchmark for stability.
And defining those healthy parameters is so essential because the moment a newborn falls outside that range, that's when our vigilance has to ratchet way up.
That's right. On the low end, we encounter the small for gestational age, or SGA, infants. By definition, SGA means the infant weighs less than the 10th percentile for their gestational age.
Which at term means less than 2,500 grams.
Exactly. Less than 2,500 grams.
Okay, and this is where we have to nail a really critical clinical distinction, one that the sources emphasize is confused all the time. The difference between SGA and intrauterine growth restriction, or IUGR. So why is identifying that specific pathology so important for the nurse?
Because FGA is just a descriptive term for size. It's a measurement. IUGR is the pathologic counterpart.
I see.
IUGR signifies that something fundamental, a disease process, usually involving the maternal placental fetal unit, actively restricted that baby's growth potential. So this knowledge helps the nurse to anticipate specific systemic failures, especially the metabolic ones.
So the baby might be small, but the crucial question is why.
Exactly. Why?
And that why often dictates the prognosis, right? Which is where the types of IUGR becomes so important. We've got symmetric and asymmetric.
Correct. Symmetric IUDR is it's the more severe type. It often represents a growth failure that happened very early in the pregnancy.
How early?
We're talking first trimester. This infant shows an equal delay in the growth of all organs, including the head. Clinically, this suggests a chronic, long-standing issue, maybe a severe early infection or a genetic condition. And it's often associated with poorer long-term neurological outcomes because the whole brain was compromised.
But the more common presentation is asymmetric IUGR, and that tells a different story about the body's coping mechanism.
A very different story. In asymmetric IUGR, the growth restriction happens later, maybe in the third trimester. It's often due to placental insufficiency caused by something like maternal hypertension or chronic hypoxemia.
Okay.
The body, in this remarkable act of triage, sacrifices somatic growth, the body and the liver, to preserve the most critical organ, the brain.
So it's a survival mechanism.
It is. The brain growth is preferentially preserved. So upon assessment, what you see is a large head relative to a small, thin body. The clinical implication here is that while the infant may have better neurodevelopmental potential than the symmetric counterpart, they are metabolically starved and at immense risk for immediate problems like hypoglycemia.
And the risk factors are a huge part of this puzzle. The sources list a whole gamut of maternal issues that lead to that placental compromise: hypertension, lupus, severe hypoxemia from anemia or COPD.
Right, and also substance use and severe malnutrition. Knowing those risk factors allows the nurse to anticipate an SGA baby's needs even before they're born, and those needs are made visibly clear during the physical assessment.
Okay, let's detail that assessment. The sources describe the SGA infant as having a wasted appearance. What specific signs is the nurse actually documenting?
So we're looking for evidence of poor nutrient storage.
Mhm.
First, the head appears disproportionately large, which confirms that asymmetrical pattern we just talked about.
Right.
You'll see a visibly wasted appearance of the extremities, almost skeletal. Crucially, there's significantly reduced subcutaneous fat stores. This lack of insulation means they have zero reserve against cold stress, which is a key reason warming them is an absolute priority.
That makes sense.
Their abdomen looks scaphoid or sunken in. That's a direct sign of depleted glycogen stores in the liver. Their skin might look loose and dry, almost oversized for their frame, and they might have a thin, thread-like umbilical cord because the placenta itself was poorly perfused.
Wow, that paints a very compelling clinical picture. So knowing this metabolic vulnerability, what are the absolute immediate nursing management priorities for that SGA infant right after birth?
Every single intervention is aimed at restoring stability and conserving energy. First, meticulous documentation of all measurements, weight, length, head circumference, to confirm the diagnosis.
Okay.
Second, because of those depleted glycogen stores, frequent blood glucose monitoring is critical. Third, stabilizing their temperature. Keeping the infant warm, usually under a radiant warmer, is central because cold stress burns up their already limited energy reserves exponentially.
And the final, life-saving intervention.
Initiating early and frequent feedings. We have to quickly replace those missing energy stores through oral intake, or if that fails, through IV dextrose.
Now let's flip the coin and look at the opposite extreme, large for gestational age, or LGA. These are babies weighing more than 4,000 grams or above the 90th percentile. So while SGA babies are starved, LGA babies are often overnourished in utero.
That's a good way to put it. Correct. And while they look robust, this group comes with a very distinct and immediate set of acute risks, particularly centered around delivery trauma due to their sheer size.
Right, the mechanical issues.
Yes, exactly. The high risk of birth injuries includes potentially debilitating conditions like shoulder dystocia, where the anterior shoulder gets stuck behind the pubic bone clavicular fractures, and various nerve palsies like facial paralysis or brachial plexus injuries. This just necessitates a very high incidence of operative delivery.
And the risk doesn't stop at delivery. The sources also highlight a long-term risk for LGA babies. This idea of metabolic programming that increases their risk for obesity, insulin resistance, and heart disease later in life.
And the major pathological cause for LGA, the one that triggers the most clinical vigilance, is maternal diabetes, either pre-existing or gestational. The key here really is prevention, achieving good glycemic control for the mother, ideally starting before conception.
Mhm.
Our sources note that strict prenatal glucose management can significantly reduce the risk not just of macrosomia, but also of serious congenital malformations, particularly CNS anomalies like spina bifida and cardiac defects.
Okay, let's hone in on infants of diabetic mothers, or IDM. The paradox here, as our sources note, is that while these infants are often longer and weigh more, that sheer bulk does not equate to physiological maturity.
That is the absolute crux of the IDM challenge. Maternal hyperglycemia forces the fetus to produce excess insulin, fetal hypoinsulinemia, which acts as a powerful growth hormone.
Right.
This leads to increased organ size, visceromegaly, and excessive fat deposits, macrosomia. But this process also often interferes with the production of surfactant. This puts the IDM baby, even if born at term, at a much higher risk for respiratory distress syndrome compared to a non-IDM baby of the same age.
So if the SGA baby is wasted, what's the specific appearance a nurse should look for in an IDM baby that flags this specific pathology?
The characteristic appearance is one of exaggerated size, but often poor tone. You might see full, chubby cheeks, a ruddy, plethoric color from high hemoglobin, a short neck, large shoulders, and just generally fat extremities.
So they don't have that dry, loose skin of the SGA infant.
Not at all. And the nursing management immediately mirrors the LGA care regarding vigilance for birth trauma. But the paramount priority here, just like with SGA, is managing that acute metabolic instability, specifically hypoglycemia.
Which is the core concern linking all these high-risk groups. Hypoglycemia, defined as blood glucose less than 2.6 millimol, is a universal high-risk factor for LGA, SGA, preterm infants, and IDM babies. It's also precipitated by acute stressors like cold stress or infection.
And the reason 2.6 millimol is that critical threshold is because below this level, the brain's primary fuel source is critically depleted. You're risking permanent neurological damage. Therefore, the clinical signs of hypoglycemia are the absolute red flags that necessitate immediate aggressive intervention.
Let's detail those signs for the learner. I mean, what does hypoglycemia look like beyond just a number on a strip?
It presents systemically. Neurologically, you'll see lethargy, irritability, or maybe a high-pitched weak cry. The baby might be jittery, which is often mistaken for a normal startle, but it can progress rapidly to seizures.
Wow.
Systemic signs include temperature instability, they're cold, and they struggle to warm up, poor feeding, apneic spells, cyanosis, pallor, and profound hypotonia, or floppy muscle tone. If you see these signs, you must assume hypoglycemia until you prove otherwise and act immediately.
The nursing management protocol for glucose monitoring and intervention is so detailed and incredibly time-sensitive. Can we walk through the exact steps outlined in the sources?
Of course, the first step is protocol adherence. Initiate glucose screening in the first 2 hours after the first feed, or immediately if the infant is symptomatic or high risk. This monitoring continues until feeds are well established and the infant is asymptomatic per your unit's protocol.
And the procedure for getting the sample itself requires really careful technique.
It does. When performing the heel stick, the nurse must warm the foot first. This encourages vasodilation and better circulation, which leads to a good free-flowing sample and prevents the need for repeated sticks.
Right. Less trauma for the baby.
Exactly. And crucially, pain management has to be integrated. Use skin-to-skin contact, facilitate immediate breastfeeding, or administer sucrose drops for pain management before the stick.
And what about that critical safety tip regarding the site of the stick? What must be avoided and why?
You must avoid the central curvature or the plantar surface of the heel. This area is too close to the calcaneus bone and nerve bundles, risking injury or even osteomyelitis. We stick only the lateral aspects of the heel. Furthermore, you cleanse the area, perform the stick with a lancet no deeper than 2.4 millimeters, and critically, wipe away the very first drop of blood before you collect the sample.
And the rationale for wiping away that first drop, I think a lot of people miss that.
They do. That first drop is contaminated with tissue fluid, which can dilute the sample and lead to a falsely low blood glucose reading. A falsely low reading could unnecessarily trigger an intervention like IV dextrose when the baby might have been totally stable. We need accuracy.
Once a low BG is confirmed, the first-line treatment is aggressive nutritional support, right? Leveraging the body's own stabilizing mechanisms.
Absolutely. We promote feeding within 30 minutes after delivery, recognizing that breast milk provides the best lipid and glucose balance for sustained glycemic stability. The nurse has to insist on feeds every 2 to 3 hours at a minimum.
So the goal is aggressive feeding to prevent the need for an IV.
That's the goal. We monitor BG levels every 3 hours until the infant achieves 3 consecutive normal readings. That's a standard benchmark, indicating metabolic autonomy and stability. And beyond glucose, the nurse must also monitor these high-risk babies for signs of polycythemia, an excess of red blood cells, and hyperbilirubinemia, both of which are common complications in both LGA and SGA populations.
Okay, let's transition now to prematurity, which is defined as birth before 37 weeks gestation. In places like Canada, these infants make up about 8% of births. And while modern medicine has drastically reduced mortality, the sources stress that high morbidity long-term health problems remains a huge challenge.
The health risks of prematurity are systemic because all major organs are immature. This fundamentally hinders a smooth transition to extrauterine life. We're talking about long-term consequences that can include profound neurodevelopmental disorders, intracranial hemorrhage,
IVH, right.
IVH, chronic lung disease or BPD, retinopathy of prematurity, ROP, and hearing or vision deficits. The fact that their brain development is incomplete just predisposes them to these lifelong morbidities.
And there's a specific segment that often fools clinicians, necessitating extreme vigilance: the late preterm infants. These are babies born between 34 weeks and 36 weeks and 6 days, and they make up about 3/4 of all preterm infants.
This is what I call the preemie paradox. They look robust, they look almost like term babies, but they are absolutely not physiologically ready. They still face significant measurable challenges: increased risk for respiratory distress, profound challenges with thermoregulation, persistent hypoglycemia, severe jaundice, and exhausting feeding difficulties.
So you have to approach them with the same high index of suspicion.
Almost the same as a much smaller preemie. You have to know their appearance is deceptive.
To properly tailor the nursing care, we need to understand the physiological deficits system by system. Let's start with the most acute concern, the respiratory system.
The deficits here are a perfect storm for respiratory failure. They have a decreased number of functional alveoli, deficient production of surfactant, that's the slippery substance that keeps lung sacs open, and a smaller, more collapsible airway lumen. This all means they require higher pressures to breathe, which leads to early exhaustion.
And this demands that the nurse master a critical assessment distinction, telling the difference between periodic breathing and true apnea.
hmm Periodic breathing is normal, especially in sleep. It's a short 5 to 10 second pause, followed by 10 to 15 seconds of rapid compensatory breathing. It resolves on its own.
But an apneic spell is different.
An apneic spell is a true medical event. It's a cessation of breathing for 20 seconds or more, or a shorter pause if it's accompanied by bradycardia, a slow heart rate, or cyanosis turning blue. This requires immediate nursing intervention, starting with tactile stimulation. If that fails, it escalates to ventilation via bag valve mask and potentially supplemental oxygen or CPAP.
Okay, moving to the cardiovascular system. The sources note increased capillary fragility and decreased production of red blood cells, which puts them at risk of anemia. But the major immediate cardiac defect is the persistence of the patent ductus arteriosus, or PDA.
The PDA is the fetal connection between the aorta and the pulmonary artery that's supposed to close shortly after birth. In preemies, because of poor oxygenation and the continued presence of certain circulating hormones called prostaglandins, it often fails to close.
And if it stays open, what happens?
If it remains open, it results in a problematic shunt, typically left to right, causing blood to flood the lungs.
And that excess blood flow back into the pulmonary circulation causes two major issues.
Cardiac enlargement and pulmonary edema. Nursing management here involves closely monitoring for signs of fluid overload, like a bounding pulse or crackles in the lungs. Medical management involves restricting fluid volume and administering specific drugs, like indomethacin or ibuprofen, which work to inhibit prostaglandin production, thereby encouraging the ductus arteriosus to constrict and close.
And if that doesn't work?
If medicine fails, surgical ligation is necessary. The nurse needs to understand that this is a race against time to protect the lungs.
Next, the gastrointestinal, or GI, system. This is where the nutritional challenges are centered.
The GI tract is just underdeveloped. The critical deficit is that the coordinated suck, swallow, and breathe reflexes, a really complex neurological achievement, are not fully synchronized until 36 to 37 weeks gestation. Any infant born before that just cannot feed safely or efficiently.
On top of that, their gag reflex might be weak.
Very weak, making them highly prone to aspiration, and they lack sufficient nutritional stores to begin with.
So if independent feeding is unsafe, what is the standardized intervention?
They require assisted feedings, typically enteral. This is gavage feeding delivered via a nasogastric NG or orogastric OG tube. In cases of extreme prematurity or complex issues, they might rely on parenteral nutrition, so IV, or long-term gastrostomy feeding.
And there's a crucial nursing detail there.
Yes, the feedings must be done extremely slowly. Why? Because the immature gut tolerates volume poorly, and rapid feeding can lead to devastating conditions like necrotizing enterocolitis or NEC. The nurse must also check gastric residuals before each bolus feed to ensure the stomach is emptying properly.
And just briefly, the renal and immune systems also show profound immaturity, which makes overall management a real tightrope walk.
It really is. The renal system is immature, struggling to perform basic functions. It fails to adequately excrete metabolites, it struggles to concentrate urine, which leads to a higher risk of dehydration, and it finds it difficult to maintain fluid, electrolyte, and acid-base balance.
So stripped I's and O's are essential.
Meticulous. Strict fluid intake and output calculations. Even minor errors can lead to serious complications. And critically, their immune system is significantly compromised. They lack mature T and B cell function and passive immunity. They are at the highest risk of hospital-acquired infection and sepsis. Early identification of the subtle signs of sepsis, like a minor temperature fluctuation, lethargy, or poor feeding, is life-saving.
Let's consolidate this. What does a full nursing assessment of prematurity look like? It's really a complete checklist of immaturity markers.
The nurse is systematically looking for confirmation of physical immaturity. We note the low birth weight, the scrawny appearance, the large head relative to the chest. Specific markers include large amounts of lunigo, that fine downy hair,
Right.
very soft pliable ear cartilage that easily folds over, thin transparent skin through which veins are visibly apparent, few creases on the palms and feet, and underdeveloped genitalia undescended tests in males or prominent labia in females.
And the immediate management checklist is a comprehensive stabilization plan that overlaps with our earlier discussion on SGA care.
Absolutely. The priorities are sequential. Monitor vital signs closely, ensuring adequate oxygenation and O2 sats. Initiate resuscitation according to NRP if necessary. But the core stabilization interventions are universal, maintaining meticulous temperature control and keeping the baby warm, checking blood glucose frequently to prevent a metabolic crash, and aggressively promoting nutrition and fluid balance.
Of all those interventions, the sources emphasize two areas requiring special nursing diligence.
First, meticulous and continuous skin care. The preemie skin is single-layered, delicate, and highly permeable. This leads to a massive risk of insensible water loss. They just evaporate water quickly, and easy breakdown, which is a portal for infection. We use hydrocolloid dressings and minimal tape.
And the second area.
Infection control. It is non-negotiable. Strict hand hygiene and aseptic technique are paramount, given their profoundly compromised immune status.
Shifting gears now to the most common challenge in newborn care, jaundice. This condition affects 60 to 80% of term infants, and it's the leading cause of readmission globally. Jaundice is caused by the deposition of unconjugated bilirubin in the skin and mucous membranes. To understand the danger, we need to understand the process.
Right, bilirubin is the natural byproduct of red blood cell breakdown. At birth, the baby suddenly has to process a huge load of fetal red blood cells, which have a shorter lifespan. This breakdown creates unconjugated or indirect bilirubin.
And that's the toxic form.
That's the toxic insoluble form. It has to be bound to albumin to be transported to the liver. The liver then performs conjugation, creating conjugated or direct bilirubin, which is water-soluble, combines with bile, and is finally excreted via the GI tract in the stool.
So physiologic jaundice is the normal, expected manifestation when the liver simply can't keep up with that initial load.
Precisely. Typically appears after 24 hours of life, usually 3 to 4 days after birth, and it peaks around 72 hours. It's benign, self-limiting, and requires no aggressive treatment, but it is exacerbated by anything that slows excretion.
For instance,
Delayed passage of meconium, which traps bilirubin, and poor feeding. Both dramatically increase the risk.
And clinically, where does the nurse first notice it?
The progression is cephalocaudal head to toe. It's first noticed in the head, specifically the sclera and mucous membranes, and then it progresses downwards to the thorax, abdomen, and extremities. A crucial assessment note here. Physical inspection using blanching is significantly less accurate in dark-skinned newborns.
That's so important.
It is. We cannot rely on visual assessment alone. We have to use transcutaneous bilirubin or serum bilirubin checks to confirm levels, especially if there are risk factors present.
The real danger, and the reason for such high vigilance, lies in pathologic jaundice, where levels rise rapidly within the first 24 hours, often reaching dangerous peaks 340 to 425 millimol.
The major danger of pathologic jaundice is the risk of neurotoxicity resulting in kernicterus. Kernicterus is bilirubin encephalopathy. When unconjugated bilirubin reaches toxic levels, it's no longer safely bound by albumin and it's fat-soluble, allowing it to cross the blood-brain barrier and deposit irreversibly in the basal ganglia and brainstem.
And that causes devastating long-term neurological fallout.
Devastating, including severe athetoid cerebral palsy, hearing loss, and potentially death. The urgency of intervention cannot be overstated.
What specific risk factors must the nurse identify immediately that raise the flag for pathologic jaundice?
The most common and highest risk cause is blood incompatibilities, like Rh or ABO incompatibility, where maternal antibodies rapidly destroy the infant's red blood cells. Other causes include anything that increases the bilirubin load, polycythemia, large bruising or hematomas, like a cephalohematoma, which release huge amounts of bilirubin as they break down. Infections like the torch group, prematurity, and certain medications given to the mother during labor. Vigilance is based on identifying any process that rapidly breaks down red blood cells.
So what does this all mean for nursing care? Our primary goal is twofold: prevention through early stabilization, and if jaundice is present, rapid intervention to promote excretion.
Prevention starts with the basics: rigorous monitoring of risk factors and establishing frequent, efficient feeds. This is the absolute intervention priority. Why? Because increased input equals increased output. The more frequently the baby feeds, the more volume moves through the GI tract, the more often they stool, and the more they excrete that conjugated bilirubin. You're literally flushing the system.
If feeding isn't enough to manage rising levels, we move to phototherapy as the primary treatment. Can you detail the mechanism and why it's so effective?
Phototherapy is brilliant because it bypasses the immature liver entirely. It uses high-intensity light in the blue-green spectrum to penetrate the skin. This light energy changes the shape and structure of that toxic, insoluble, unconjugated bilirubin. It's a process called photosaumerization and makes it water-soluble.
So it can be excreted without the liver?
Exactly. Once it's water-soluble, it can be excreted directly through the urine and bile without needing the liver to conjugate it.
And the specifics of the nursing care protocol under the phototherapy lights are extremely rigorous.
They demand meticulous attention. First, confirm the order and immediately implement therapy. Eye protection is non-negotiable. Patches must be properly applied and secured to prevent retinal damage. The baby is stripped down to a diaper to maximize skin exposure.
Okay.
The nurse must monitor the lamp's energy output with a photometer regularly to ensure therapeutic efficacy. And the standard distance from the light source, typically 45 to 50 centimeters, has to be maintained.
What about managing the baby's physiological status while they are under that intense light?
Well, phototherapy dramatically increases the baby's metabolic rate and causes significant insensible water loss. So, maintaining hydration is critical. The nurse must meticulously monitor urine output and aggressively provide frequent feeds of breast milk or formula, often scheduling them every 2 hours.
Right.
We also monitor the baby's temperature closely, as they're prone to overheating under the intense light, which can worsen their metabolic state. And finally, the nurse is the primary educator, providing constant reassurance and explanation to the family about why this tanning bed approach is necessary and safe.
And what is the expected clinical benchmark for effectiveness?
If therapy is effective, we expect to see bilirubin levels start decreasing within 4 to 6 hours of initiation. Clinical standards suggest the level should drop by 30 to 40% within 24 hours, which confirms the intervention is working and reduces that risk of kernicterus. Okay, let's shift now to acute, high-stakes scenarios that demand immediate, highly skilled nursing intervention, starting with severe respiratory challenges.
Let's discuss neonatal asphyxia, the failure to establish adequate respiration.
Asphyxia is sobering because it occurs in about 10% of newborns, requiring active resuscitation. It leads rapidly to hypoxemia and acidosis, potentially causing multi-organ injury. The long-term consequences of severe, unmanaged asphyxia are severe,
Like what?
including cerebral palsy, profound learning delays, and vision or hearing deficits.
The nursing assessment has to integrate prenatal risks, but the immediate management focuses intensely on the ABCs.
Assessment of airway, breathing, and circulation must be immediate and concurrent. If necessary, the nurse initiates resuscitation according to the Neonatal Resuscitation Program, or NRP, algorithm. The absolute first steps are providing warmth and tactile stimulation, then positioning the airway and ensuring the baby is dried immediately to prevent rapid heat loss, which exacerbates metabolic acidosis.
And you continue until?
Resuscitation efforts continue until the pulse is above 100 beats per minute with established crying, breathing efforts, and good muscle tone. And crucially, while the physical resuscitation is ongoing, the nurse must also support the parents with continuous, calm information and explanations.
Next, respiratory distress syndrome, or RDS.
RDS is fundamentally caused by prematurity and the resulting lack of pulmonary surfactant. The symptoms grunting, nasal flaring, and retractions worsen rapidly if untreated. The management begins with stabilization, administering oxygen, drawing necessary labs, and often involves transferring the infant to the NICU for further support, which might include CPAP or mechanical ventilation to keep those tiny alveoli open.
But we have ways to prevent it now.
We do. The good news is that prenatal administration of steroids to the mother has drastically improved outcomes by accelerating fetal lung maturity.
And meconium aspiration syndrome, or MAS. This happens in a significant minority, 8 to 20% of term births.
MES occurs when a newborn aspirates meconium, typically during a period of intrauterine stress. This inhaled meconium causes a devastating cascade. It physically obstructs the small airways, it chemically inactivates existing surfactant, and it creates a severe chemical pneumonitis or inflammation.
Leading to hypoxia.
It leads quickly to hypoxia and, in severe cases, persistent pulmonary hypertension and death.
The nursing assessment is both visual and auditory.
It is. Visually, the nurse assesses the amniotic fluid for green staining and then checks the newborn's nails, cord, and skin for evidence of staining. Upon observation, you'll see symptoms of respiratory distress, intercostal and subcostal retractions, cyanosis, and grunting.
And when you listen to the lungs...
When you auscultate the lungs, a critical finding is coarse crackles, indicating fluid or inflammatory exudate in the airways.
And a management of confirmed or suspected MAS.
It requires immediate multidisciplinary collaboration. You call respiratory therapy, resuscitate according to NRP protocols when it's safe, and continuously monitor vital signs to ensure adequate oxygenation and perfusion. We maintain strict thermal control and administer oxygen as ordered, often requiring high-flow systems or mechanical ventilation until that chemical pneumonitis resolves.
Speaking of challenges associated with delivery, let's touch on birth trauma assessment. Birth involves tremendous physical forces, compression, torque, traction.
And injuries sustained are highly dependent on identifiable risk factors: fetal macrosomia, abnormal fetal presentation, prolonged or precipitous labor, or the use of instruments like forceps or a vacuum extractor. The nurse is the critical screener here.
What's the core nursing assessment protocol for suspected trauma?
First, a thorough review of the labor and birth record to identify those risk factors. Then, a meticulous physical and neurological exam. The nurse must specifically inspect the head for lumps and bruising, distinguishing between a caput succedaneum soft swelling that crosses suture lines and is benign, and a cephalohematoma, which is a blood collection that does not cross suture lines and can lead to significant hyperbilirubinemia.
Okay.
We observe for asymmetry or paralysis, carefully checking for facial palsies, or asymmetry in arm movement, which could indicate a brachial plexus injury. And crucially, gently palpate the clavicles and down the extremities for any crepitus or swelling, which flags a potential fracture. Throughout all of this, providing reassurance and honest, direct information to the parents is essential.
Now let's pivot completely. We've talked about acute injuries caused by the physical forces of delivery. Let's shift to a challenge that requires sustained, non-pharmacological vigilance and immense family support: caring for the substance-exposed newborn.
We are focusing on infants exposed to substances in utero. Everything from illicit drugs to tobacco and prescription medications like SSRIs. The current evidence-informed standard of care is the Eat, Sleep, Console model, or ESC.
And the ESC model represents a really significant philosophical shift.
It's a harm reduction approach, focusing heavily on comfort, maximizing non-pharmacological interventions, and deeply integrating the family into the infant's care plan. Our sources emphasize using the correct language. We shift away from the word addiction and refer to a drug-exposed newborn or one experiencing neonatal abstinence syndrome, NASEOS, because the signs we observe are physiological, not behavioral, even if they look like agitation.
The nursing assessment is dual-pronged: detailed history review and relentless physical symptom identification.
You have to review the maternal history thoroughly for all substance and medication use. Then, the nurse begins systematic observation, looking for the telltale signs of withdrawal, which are primarily related to central nervous system hyperarousal. These babies are irritable, difficult to settle, and often exhibit a high-pitched, incessant cry. They struggle with the basic mechanics of life: trouble sleeping, difficulty feeding, sucking, or gaining weight.
What are the specific measurable physical signs that trigger diagnostic scoring?
We look for autonomic overstimulation, fast breathing, orthotypnia, a frequent stuffy nose, and excessive sneezing or yawning. A critical physical sign is loose, watery stools, which cause severe skin irritation and breakdown in the diaper area, so that demands meticulous skin care.
And motor sign?
Motor signs include trembling or jitteriness even when they're asleep, and hypertonia, stiff arms, legs, or back. They are profoundly oversensitive to routine handling or touch and have a constant, non-nutritive need to suck, often on a pacifier. The most serious potential manifestation is seizures.
The nursing management, based on that ESC model, centers on environmental adjustments and comfort promotion.
The non-pharmacological interventions are the first-line treatment. We create a low-stimulation environment, low lighting, quiet noise levels, and gentle vertical rocking rather than vigorous bouncing. Swaddling is essential for containing the tremors and hypertonia.
Okay.
We encourage the constant use of a pacifier, as sucking provides neurological organization. The nurse's monitoring is critical. Meticulous monitoring of weight, input, and output, and extreme vigilance for skin breakdown from those frequent loose stools.
And then there's the crucial decision point for escalating care, which uses the standardized NAS scoring protocol, often the Finnegan scale.
NAS scoring begins within hours of delivery. The scores quantify the severity of the withdrawal symptoms. A score of 8 or higher is the threshold that requires more frequent assessment, maybe every 2 hours. The clinical decision to initiate pharmacological intervention, the second-line therapy, is made if the score remains at 8 or above for 3 or more consecutive assessments.
And what medications are used?
The medications used are usually opioids like morphine or methadone, or adjuncts like phenobarbital or buprenorphine, titrated specifically to suppress the most severe symptoms, like persistent high-pitched crying, tremors, or vomiting. And throughout this entire process, strong psychosocial support is mandatory, utilizing specialized support workers, unit social workers, and social services for harm reduction planning and family unification efforts. Okay, moving to infections. These represent an emergency scenario in newborns and require rapid identification and the initiation of very specific treatment protocols as they can quickly progress to life-threatening sepsis.
Let's start with Group B streptococci, or GBS.
GBS is a gram-positive organism and it remains the leading cause of early-onset sepsis in term newborns. It presents as bacteremia, meningitis, or pneumonia.
Hmm.
Given the speed at which neonatal sepsis progresses, if a newborn is suspected of having GBS infection, or if the mother was GBS positive and inadequately treated, immediate empirical antibiotic therapy is initiated.
And what is the therapy of choice? Why is that specific combination often used?
The therapy of choice is often a combination of ampicillin or penicillin, combined with an aminoglycoside, like gentamicin. This combination is crucial because it provides broad-spectrum coverage against the most common neonatal pathogens, including GBS and gram-negative organisms, while you wait for the lab results to confirm the exact pathogen. Rapid initiation of this protocol is absolutely life-saving and reduces the risk of long-term neurological sequelae from meningitis.
And maternal STIs also pose significant systemic risks transferred across the placenta or during delivery.
Syphilis is profoundly dangerous because it crosses the placenta, risking stillbirth, prematurity, or hydrops fetalis. HIV can be acquired in utero or during delivery, necessitating adherence to strict SOGC guidelines for infant testing and potential prophylaxis.
What about others?
Infections like gonorrhea and chlamydia are passed during birth and pose a risk of ophthalmia neonatorum, which is a severe eye infection. This requires prophylactic eye treatment for all newborns and systemic antibiotics if they're symptomatic. The nurse's diligence in knowing the maternal status is really the first line of defense for anticipating these specific infections and interventions.
And finally, a brief look at congenital defects, focusing on cardiac anomalies. Our sources correctly highlight the limitations of the simple cyanotic versus acyanotic classification.
Yeah, the traditional classification is just too simplistic for guiding clinical care. The most useful system for cardiac defects is the hemodynamic one, which is based on the actual pattern of blood flow within the heart and great vessels. This system immediately informs management and prognosis.
Can you elaborate on those hemodynamic categories?
We classify them into 4 categories. First, defects with increased pulmonary blood flow, where blood shunts from the left side to the right side and floods the lungs, like a VSD or a patent ductus arteriosus. Second, defects with decreased pulmonary blood flow, where an obstruction restricts flow to the lungs, causing systemic desaturation, like tetralogy of Fallot. Third, obstruction to blood flow out of the heart, like aortic stenosis. And finally, mixed blood flow defects, like transposition of the great arteries, where oxygenated and unoxygenated blood is blended.
And there's a crucial clinical note here that challenges the assumption that cyanotic defect means a baby will look blue right away.
Exactly. Infants with deeply cyanotic defects, like transposition of the great arteries, may not appear cyanotic initially, but may present subtly with severe signs of heart failure or rapid deterioration. Conversely, infants with acyanotic defects, like a large ventricular septal defect, may eventually develop cyanosis later as their pulmonary pressures rise and the shunt direction reverses. Vigilance, monitoring feeding ability, checking for subtle signs of respiratory distress, and tracking weight gain are often more reliable than simply relying on initial color.
We covered a tremendous amount of ground today. We went from immediate stabilization protocols for metabolic instability in SGA and IDM babies, all the way through the systematic immaturity challenges of preemies, the critical intervention required for jaundice, and that holistic, comfort-focused care mandated by the ESC model for substance exposure.
The key takeaway for you, the learner, is the interconnected nature of critical neonatal care. You have to be vigilant for all of these conditions simultaneously. Notice how the fundamental nursing management steps, keeping the baby warm, monitoring blood glucose, and promoting early and frequent feeding, are common threads throughout every condition we discussed.
Right, they keep coming up.
They do, because they address the basic physiological stability challenges, thermoregulation, nutrition, and metabolic balance that are common to nearly all complicated newborns. Knowledge isn't just about spotting the problem, it's about executing the precise, timely intervention based on these protocols.
It's a profound testament to the power of structured, prioritized care.
It is. We spent time detailing how prematurity prevents the coordinated suck, swallow, and breathe reflexes from maturing until 36 to 37 weeks, making independent nutritional intake impossible for younger infants. So considering how fundamental those actions are for survival and long-term development, what kind of future innovations in nutritional delivery or specialized feeding technology might drastically reduce morbidity for those infants born just a few weeks shy of term? Perhaps focusing on dynamic responsive gavage systems or even artificial placenta technology, something to mull over as you continue your own deep dive.